Ladies and gentlemen, thank you for joining us today. We now have your presenters in conference. Please be aware, each of your lines is in a listen-only mode. It is now my pleasure to introduce today's first presenter, Ms. Ann Seymour. Please go ahead, ma'am.
Thank you, David, and welcome everyone to Road to Resiliency, where we'll be discussing the importance of recovery and rebuilding in the aftermath of mass violence incidents. Grateful to the American Hospital Association for sponsoring today's webinar. And this is the fourth in a series where we'll be discussing strategies to support victims of crime in the aftermath of mass violence crimes. We would not be doing this important work without the support of the Office for Victims of Crime within the U.S. Department of Justice, who require us to say that our opinions are ours alone and do not necessarily reflect those of OVC or the entire Department of Justice. We've got three important learning objectives today. Hopefully at the end of the webinar, y'all will be able to demonstrate why it's important to identify and address the concerns of victims and survivors and, very important, caregivers and responders to sustain long-term recovery after mass violence incidents. Long-term sometimes can be a lifetime. We want you to be able to describe evidence-based strategies that can help build resilient facilities and communities. And for me personally, it's important to note that we've learned so much since 1986, the postal mass shooting in Edmonds, Oklahoma. Every time there's a MVI, we learn more and we create a strong evidence base that improves our response in the future. And finally, we want to be able to help you locate resources available from the National Mass Violence Victimization Resource Center, heretofore referred to as the Center. Lots of resources for hospital and health system CEOs that can help you all prepare for and respond to and recover from, and super important, to remain resilient in the face of mass violence incidents in your communities. I'm Ann Seymour. I've been a National Crime Victim Advocate for 36 years. I am the Associate Academic Program Director at the Center. We have just a fantastic, stellar panel for your discussion here today. I'd like to introduce Dr. Anna Newcomb, who's not only the president of the American Trauma Society, she is a research manager and communications faculty at the Inova Health System in Fairfax, Virginia. My colleague, Aurelia Sands-Bell, has been a national victim advocate for, I think, about 40 years. She is a research instructor with the center and a font of experience in the victim services field. And my great friend and someone I admire a lot is Julie Paez. Julie is the survivor of the mass shooting in San Bernardino in December 2015. She's also been an amazing contributor as part of our stakeholder group of survivors, responders, and victim service providers that guide the work of our center. So welcome to our panel. I'm very, very excited about rich discussion that we're going to be having today. I want to tell you a little bit about the center. We are located in Charleston, South Carolina. We are part of the wonderful Medical University of South Carolina, obviously supported by the U.S. Department of Justice. We have a pretty clear vision. We just want to make sure that victims and survivors of mass violence, including first responders, including communities, get very good services that have an evidence base, that are survivor-centered and trauma-informed. And the last part is really important. We want to make sure we're respectful of victims' needs and wishes. And this leads us to our mission statement. The center wants to improve community preparedness and our capacity to serve victims recovering from mass violence through a combination of research, planning, training, technology, and collaboration. So that's who we are. If you look nationally, there are several definitions of mass violence incidents. The FBI has one, Congress has one. For the purposes of today, we're going to use the Office for Victims of Crime's definition, very important as a foundation for our discussion. They call an MVI an intentional violent criminal act for which a formal investigation has been opened by the FBI or another law enforcement agency that results in physical, emotional, or psychological injury to a sufficiently large number of people as to significantly increase the burden of victim assistance and compensation for the responding jurisdiction. And the important part here is the burden of providing victim assistance becomes more than some communities' capacity to be able to meet the needs. That is the definition of an MVI. What have we learned from experiences and studies of crime and mass violence incidents? First and foremost, exposure to these, unfortunately, is highly prevalent. There is no community that is immune from the threat of mass violence incidents. Most victims don't develop mental health disorders, but many do. A lot of victims recover on their own. Others need assistance, and we do know that the degree of social support, we'll be talking more about that, is one of the most important protective factors. Most victims do not seek mental health treatment, which is very important for the healthcare community to recognize. Sometimes it's due to stigma, and sometimes it's a lack of access. They're not aware of services that are available, or they do not have transportation to get to the services. Certainly now in the pandemic, we have significant shared challenges in terms of accessibility of services. What's the exposure of MVIs? We know that mental health problems tend to increase. Health risk behaviors and health problems increase. Very often school and job performances are detrimentally affected in the aftermath of MVIs. And very important, very often people change their lifestyle. They change who they are, how they act, and their personal behaviors because of fears related strictly to the experience of being a victim of a mass violence incident. And speaking of people being changing their behaviors and being afraid, a year ago in September 2019, there was a Gallup poll that found that 45% of Americans worry about being a victim of mass shooting, including a lot that are very or somewhat worried. And so think about that. Nearly half of folks in our country have very real concerns about being involved in a mass violence incident. Mass violence incidents and other large-scale criminal incidents, such as the burning in Paradise, the wildfires in Paradise, California, want to talk about the problem in brief. We know that they are occurring much more often. We know that they produce deaths and physical injuries and health concerns with increased risks of all kinds of problems among survivors and family members and also among first responders and victim service providers. I can assure you that law enforcement response over the decades to mass violence incidents has improved dramatically, but very often there's a lack of accurate information about best practices and what are the victim survivors' needs. In our field, we always say, how do you find out what a victim needs? And the answer is really simple. You just ask them. It's really important that we focus on improving our first responder actions related to MVIs by making sure that we're tapping into what the victim's needs are. Survivors often lack access to accurate information. Self-help tools with technology, we're becoming increasingly creative on doing work that's online and that's things that people can do themselves, and also focusing on what are the evidence-based mental and behavioral health treatments that are most important. I think the last point here goes without saying, but I'm going to say it anyhow. The ripple effects of mass violence incidents go far behind the victims who are there and experience it in person. It goes to their family, loved ones, their coworkers. It goes to the first responders. Certainly goes to folks who work in the healthcare industry and hospitals, who are among our most important partners in responding to MVIs. And I will also say that entire communities are just dramatically affected and negatively impacted in the aftermath of MVIs. And so the ripple effects are something that we have to all be concerned about. That's the problem. I'm really happy to turn this over to my friend Julie Paez, again, a survivor of a mass shooting. The power of the personal story in the victim assistance field is what has driven us since our inception. And Julie, We're so fortunate to have you here today to talk about your own experiences. Welcome.
Thank you, Anne. As you heard, my name is Julie Paez. I was a health inspector for the county of San Bernardino at a training with all of my coworkers and friends when one of our other coworkers and his wife, who had become radicalized Muslims, entered our meeting and opened fire using AR-15s. They shot, a lot of victims. They killed 14 in the room. 22 other people were shot. About 25 to 30 people were able to get out or were unshot in the room. I was shot twice that day. The first time I was shot was through my pubic bone, and it shattered my pelvis. The second time I was shot was through my rectum. Both shots caused severe damage in my lower abdomen. I had trained as an EMT in college, and so my mind kind of went to survival mode. When I was laying there and I knew my bladder had been burst, and I knew I felt urine and blood spill out of my lower abdomen. I wasn't sure exactly where I was shot, but I knew it was lower abdomen. And I knew that I was minutes from bleeding to death. But I also knew that soon first responders would be on their way, that I would probably have 3, 4, 5 minutes, and I needed to utilize those few minutes to save my life. There were people in the room screaming. The fire extinguishers had been shot and were going, water was pouring down. There was a smell of gun powder or gunpowder, I guess, in the room, and the gunshots, just a constant going. And I knew those are things that I didn't want in my brain, so I shut them out. I tried to lower my heart rate, thinking about things that made me feel good, because I knew I needed to get to the hospital to save my life. I knew I needed to first get ambulance or something. I was, within about 4 minutes, first responders were there, a police officer who was in the area, heard shots, got over there. He actually, the shooters were gone after about 4 minutes. It was very fast. And he called out, came into the room. I raised my hand for help because I couldn't move. And he got someone else from outside to come, another officer, to drag me out. And I felt like I was on the home stretch because I was trying my best to stay, to not lose consciousness, because I needed to tell them where I was shot, because I wanted to save time on my survival, or, make it better for my survival. I was taken to a triage where I answered as many questions as I could for the EMT and the paramedic. They got me immediately into an ambulance and to Loma Linda University Medical Center, which had level 1 trauma. I barely survived. I basically died. All my blood, I had bled out, and I was replaced with, I think, 16 or 18 units of blood, and in surgery for 12 hours. They didn't think I was going to walk again, and were surprised, actually, I survived. I think from the medical side, one of the most powerful things for my survival was, I got a chance to go back and meet the ambulance drivers who saved my life. That was huge for me because I needed to kind of come full circle. I also went back and met Dexter, who was, he was the nurse in the recovery in the ICU. And I remember him talking to me, but I don't remember seeing him. I was just barely conscious. And I went back later to meet him and tell him how much I appreciated his help in saving my life. The one thing I never got to do that I regret is meeting the emergency room doctors. Because once you're moved on to another part of the hospital, we don't get to see the people who helped save our life. I stayed for the first month I was in the hospital, and I've had 6 follow-up surgeries. But I think that connection to the medical staff is really important, especially to come full circle and be able to see the people who saved my life. When Anne talked about the ripple effect, it's extremely, I thought I was going to protect my family. My daughter has PTSD from experiencing this. My son fell into a depression and lost his job as a result of the shooting. So it absolutely, as much as you try to protect family, it does reach out.
So much, and the fact that you were a healthcare professional, EMT yourself, is very touching to me. And I just want to say I do appreciate the fact that you have the opportunity now to express your gratitude to the folks in the emergency room. And I know that folks at the American Hospital Association, it's important for them to understand the gratitude that you have felt, am I right, about the treatment that you received that saved your life?
No, absolutely. And not only the gratitude, I think sometimes, and I may be speaking, without actual knowledge, but it seems that doctors, they work on you in the emergency room, in an emergency situation, you are moved on to a different part of the hospital, and they may or may not ever get to see how you are or what turned out or how you're doing. And I think it's a positive for both sides.
Right. Well, Julie, thank you so much. The power of your personal story has just been inspiring to me since the day I met you, and I know it's inspiring to folks who are joining this webinar. I'm excited to hear you as part of the panel discussion coming right up. So thank you so very much. So when the code is over, we're going to move on to talking about after action. What do we need to be doing during the recovery and rebuilding phases? And, I'd love to put a time frame on this, but I can't. It's different for every mass violence incident. What do we need to do to improve outcomes? What do staff and communities and victims require? And Julie and I have both talked about the ripple effect. It is not just the victims at the scene of the MVI. It goes far beyond that. So we're going to talk a little bit about immediate, short-term, and long-term needs. And the final question is just so important. How shall we train the next generation? We have a strong evidence base. We unfortunately have so many experiences responding to MVIs. How can we share that experiences with folks in the future? So our first question is, what do we need to be doing during the recovery and rebuilding phases? And I'm going to start with Aurelia Sandsbell. Aurelia?
Okay, Ann. I think during this particular phase, it's so important we talk about social support. We talk about victims being able to connect and have someone with them. And in addition to that, it's important that the services that we provide are provided in a trauma-informed manner. Evidence-based. What do we know that works? What are the strategies that we know work and help people? And put those things into practice. Those are key in getting through the recovery and rebuilding phase for victims. Ann?
Julie? Can you hear me?
Yes.
Okay, let's do a 3-second pause, and I'll throw it to Julie. Julie, what are your thoughts on the recovery and rebuilding phases? What do we need?
Well, I think that there needs to be immediate services. I know in my incident, because I knew everyone who was there and the people who were injured, there were people who never got counseling because it wasn't offered to them. There were people who waited 1 year to ever have counseling. And other people who were told, well, let us know if you want it. The problem is, as a victim, we don't know what we need. We're not the experts in being victims. We need someone to just tell us, this is what you have, almost like this is what you need. You have to have this. And explain to the victim what changes in their emotional state they're going to feel and going to be expecting in the next, weeks, months.
Great. Thank you so much, Julie. And I'm going to go to Anna. Anna, recovery and rebuilding process. What do we need?
It's so interesting, Anne, because I hear you talking about, and I hear Aurelia and Julie talking about the need to have immediate connections with others. And we need to be able to, as hospitals, connect those survivors with each other, with their providers, with their community resources. But the interesting thing is we cannot do that as hospitals unless we already have those pathways set up prior to this mass violent incident. So if a hospital already has a program set to support trauma survivors, connect folks, make sure that the community resources are available, the survivor has a much better chance at being able to tap into their internal resources, their external resources. But when we as a hospital system are taken off guard or are surprised, our survivors are really victims of this incident, and we will all be struggling to figure out how to care for our comrades here. So I guess my takeaway point, which I will always say, is prior to the next incident, a hospital really needs to be set up in a way that they can provide that care already.
And I really appreciate all your comments because I just think we need partnerships, not just getting along, cooperating, collaborating. We need permanent partnerships, not just for MVIs, but for victim survivors in general. And I really feel that theme resonating here, that we could do more in terms of planning to be prepared. And Julie, thank you for saying that victims don't know what they need, because that's why a good victim service professional is available to provide that kind of guidance. I do appreciate that. We're going to go next to talking about what do we need to consider for staff, communities, and victims. We've established the important theme of the ripple effect. How can we achieve this? And Julie, I'm going to start with you. How can we achieve this?
Well, again, I think counseling is really important, and to acknowledge that people, even if they're not physically injured, have injuries. I know with my incident, and that's the one I can talk about with the most clarity, is that I had coworkers who witnessed the murder of their friends and were told because they did not have an injury that they weren't injured, that because they did not have a physical injury that they didn't qualify for counseling services. Since we were at work, this all fell under workers' compensation, and so we couldn't go on our own and get services unless we were just paying cash out of pocket, because our own insurance said this happened at work, you need to go through workers' compensation. And so I think acknowledging that just because you were not physically injured didn't mean that you don't have an injury that needs to be addressed. And family members, I think the information of what to expect in the next weeks to months and what behaviors is hugely powerful. If you're told, after these mass violence incidents, that your brain will be in a fog, that your decision-making power is going to be really, really crappy, and that, you won't be able to sleep, then when those things happen, you're understanding that's just part of the process versus thinking you're going crazy.
Mm-hmm. Thank you, Julie. And it's so important to recognize in the victims field, we call that helping to predict and prepare. Victim services, mental and behavioral health providers, that is an important charge to all of us. I really do appreciate that. Anna, what are your thoughts on staff, hospital staff, communities, and victims and survivors?
Well, listening to Julie reminds me of some of the important approaches, I think, and when we move toward making resources available, I think it's useful to always remember that the survivors are the experts in their own recovery. And you had mentioned this actually in the beginning. What do they need? You ask them directly. And what we have learned through this program called the Trauma Survivors Network, which is a network clearly of trauma survivors connecting with each other and supporting each other through their recovery, is that it turns out that survivors are about the best providers in guiding the next generation of families and patients through that recovery process, because they can actually say, I've been there and I understand the pain that you're going through, whereas we providers, we can only listen and support. So I think one of the important things is just to have something like the Trauma Survivors Network in every hospital that is equipped to connect survivors with each other and connect survivors with their providers when they're ready to make that connection. That's one of the primary activities of our Trauma Survivors Network. It's a program of the American Trauma Society that connects those survivors like Julie to Dexter, so that each of those folks can experience the joy, I guess, of that recovery that survivor has worked so hard to gain.
Yeah, I thank you so much. I cannot say enough for mutual support. And survivors always say it's a club that you don't want to be part of. And the fact that they have their personal expertise from their suffering and their resiliency is something that's it's just so important. So thank you for that. Aurelia, any thoughts on staff, communities, victims?
I do. I think everything that both Julie and Anna have said are so important, because we have to recognize that we don't know who's been impacted and how they've been impacted. And as Julie said in the beginning with her examples, her children were impacted by what their mom experienced. And so we think about how traumatized an entire community can be because of these types of crimes. I also want to say that those who work in the field as first responders, as victim advocates, medical providers, whatever, are also victims of mass violence as well. And so we have to think about how we help them replenish, how do we recognize their exhaustion and their fatigue and give them a backup plan, because we can wear them out. They can be worn out within these processes. Some people are going to see things they've never seen before. Talking to some medical providers at one point where there was a shooting in a community, they had not seen that kind of injury. And so their medical staff was really stressed, and they had to be replenished, they had to be helped, because they had not seen that level of trauma. So when we think about all of this planning and putting things in place, we have to recognize that it can happen anywhere, and we have to have contingency plans for how to be supportive of everyone in these particular situations.
Thank you all. I really appreciate that, because, having responded to many mass violence incidents, and I think I'm a good victim advocate, the sheer volume of people who are harmed physically, intellectually, emotionally, and psychologically is beyond the capacity sometimes of one individual or an entire response system to be able to serve them. So I do appreciate, very much appreciate that point. And we are going to move on to my favorite topic, and that is, how do we train the next generation? How do we make sure that our knowledge, our evidence-based, our commitment to being trauma-informed and survivor-centered carries on in the future. And Anna, can we start with you on this important question?
Sure. I was just thinking about this and how one of the things that hospital staff really benefits from, even when it's not a critical incident that of this mass violent type, is having folks on hand who have been trained to provide critical incident stress debriefing, because it's not something that you can train somebody all of a sudden when this happens. So if you have a staff or a set of staff members already available to provide this kind of psychological first aid, the hospital is going to be better equipped already. And then having some staff members who are assigned to be the advocates for those new victims coming in, either as networking them to other folks who have been through this in the past, or just supporting their families. Usually these are social workers or chaplains. I think having those folks already on staff, that will be an important thing to being prepared, and training them up prior to the first incident is going to be something you can actually do, because it turns out there are a lot of smaller incidents that happen throughout our time in the hospital.
I appreciate that. When you think about the term in job descriptions, other duties as assigned, no one is ever prepared for responding to a mass violence incident. So having the other duties, people prepared, whether it's social workers, and thank you for many chaplains and medical and mental health staff, it's really important that everyone shares that commitment and really focuses on training to make that happen. Julie, what do you think about training the next generation from a survivor's perspective?
Oh, goodness. I can't add more than what Anna said. However, I do think that the hospitals do need to be prepared, because these mass violence incidents are happening. It feels like they're happening more and more. And they can be the hospitals, and they can learn from other incidents what worked and what didn't. So the after-action reports from previous incidents, if the hospitals take those and find out what worked and what didn't, whether it's the way people are maybe admitted into the hospital under a pseudonym, whether that works or doesn't work. If maybe they put aside a special room for family members or people coming in trying to find one of the survivors or one of the people that has been admitted into the hospital, and keep them separate from, for example, the media, which may also be at the hospital looking to find out who was injured. I think those things are a learning curve, and with each incident, they can be done better and better. But those are important, to keep media separate from family members, and family members able to find their loved one that has been entered into the hospital, and maybe without a name, maybe with a pseudonym. But those things need to be perfected, I think, at the hospital level.
Julie, thank you for focusing on lessons learned, because unfortunately we have so many MVI experiences from which we've learned lessons. You brought up something that is, I don't know the answer, but we lose victims. We can't find victims. And there have been so many examples, and I'm not going to name specific MVIs, where family members or people like me were not able to locate victims. And so when we talk about training in the future, I'm pretty sure you're going to support the idea of doing better systems where we can track victims even if they have a pseudonym.
Yes, absolutely.
Oh, I knew you'd agree with that. Thank you, Julie. Aurelia, she's one of the premier trainers in the entire victims field, so I can't wait to hear from you. What do we need to do about training the next generation?
Well, I think, first of all, we keep talking about it, and people have to stop thinking about, this won't happen in my neighborhood, this won't happen where I live, because we certainly have lots of examples of where it has occurred, where people live who didn't think that kind of thing would ever occur. So we're all being prompted to be vigilant and to be prepared. And I want to say that I think this is the area that the National Mass Violence Victimization Resource Center is all about. we're pulling together stakeholders. We're pulling together people who are conducting resiliency centers, and Ann's going to talk a lot more about that. We're coordinating and working with grassroots organizations and other non-governmental organizations, and they have immediate contact within the field, and as we're pulling them together, we have immediate contact with the field, and people know that we exist. And so we're training and trying to get that information up and out, and just to serve as a strong resource for our country in how we address mass violence. And so continuing to partner and cross trainings with hospitals and other medical facilities helps us to achieve this goal, and I think one of the things and great thing that the center is doing is, being a catalyst for that kind of achievement and training for our next generation.
Thank you, Aurelia, and all of you. And I just want to say from experience, I think of what happened after the mass shooting in D.C. at the Navy Yard, the bombing of the Boston Marathon. Some of the partnerships that came out afterwards between victim services, first responders, and hospitals and healthcare professionals were, and I'm going to quote Julie, they were based on the lessons learned, not always good lessons. Sometimes we make big mistakes, but to be able to move on from those experiences. And Aurelia, you mentioned something super important. We cannot operate in silos. If we're not cross-training into the future, we are totally missing the boat. So thank you all. We're going to move on to another great segment of our webinar. I'm going to turn it over to Aurelia, who probably knows better than just about anybody about the landscape of victim survivor services in the U.S., and then I'll be talking about victims' rights. Aurelia?
Okay, thank you, Ann. I think this is very important to me because many people don't know how many programs are out there and what they're doing. And it's so, and it's just dear to my heart because I started my career as a rape crisis advocate located in Grady Hospital in Atlanta, Georgia. And it was a wonderful experience because when victims came into our hospital for that exam, that rape exam, that they were triaged number 2 to life and death patients. And that's how serious Grady took that issue of sexual assault. And the beauty of being within the hospital was that every other medical need that a victim had could be met right there. It was a wonderful grounding for me many, many years ago in starting my career. And so we look around the country and we have at least 10,000 community and system-based victim assistance programs. Some of those are located in hospital settings, and there's some wonderful work that's being done now with hospital-based violence intervention programs, and those programs are just working so effectively, not only to provide direct services to victims while they're in the hospital, but to help them with ongoing needs as they go out into the community. And Kentucky has a fantastic program that's doing just that. And I'm drawing a blank on the name, but I know you can help me with that. And the other programs I'm thinking about across the country, everywhere, are the sexual assault nurse examiners programs. These programs provide the basis for the hospital teams and for community-based programs working together. So the foundation is laid in so many different ways for how advocates and medical teams work together. There are just so many laws because they have to govern local, state, tribal, federal, and Department of Defense needs. But the key takeaway here is that there are partnerships between hospitals and victim service providers, and this kind of partnership is essential if we're going to provide quality services on a continual basis. Most of you know about community-based victim service programs. You've heard of them. You've heard of rape crisis centers. You've heard of domestic violence programs, Mothers Against Drunk Driving. You've heard of so many of these programs. The beauty of these community-based programs, which I've had the pleasure of working most of my life, these programs have some latitude that sometimes other programs don't have. But the beauty is that they sit down together and strategize about how to meet the needs of their clientele. Community-based advocates are very passionate about the services they provide. I will say that you have state coalitions as well that come together and work with crime victims and help structure things in their state. Those coalitions are also of value. The last one here, the Resiliency Center, those are newer kinds of models for how services are provided to victims in the aftermath. They're the long-term services after a mass violence incident has occurred. And I think Anna's going to talk more about that as we move forward, but I do want you to know that they're often community-based programs. Our system-based programs work, just as they say, in our systems of law enforcement or courts. And these programs are there to help victims as they go through the processes of interacting with our court systems, whether civil or criminal. And I would say to you, the beauty, again, of them working together is because sometimes there isn't a court case, but they still need services. Victims still need services. So they're going to need their community-based advocates or the services that perhaps the system-based advocates can provide. So these are two basic ways that victim assistance programs operate. They provide a wide range of services, and here are some, but they're not limited to what you see here. They have basic needs that they address, and of course, crisis intervention, transportation, helping people to find housing, food, clothing in the aftermath of a mass violence incident. We see sometimes where victims have traveled to go to an event and they've been injured. They need help. How do they get home? How do they get their car keys back? Because, things have happened. They've lost their personal effects. So many things that victim advocates help them achieve and work through. So they do a lot of work, and sometimes that's not always known, but I'm going to brag a little bit on our field. We do a lot of stuff that's sometimes not known. Going forward, there's a lot of support around helping them find mental health connections and behavioral health connections, support groups. They help go to court. They accompany the court. They provide referrals for many other needs that arise that sometimes we don't even think about. But that's what the advocate does. That's what their role is. Crime victims have rights. Go ahead. Ann?
Thank you so much, Aurelia, for that just great overview of victim services. And I just want to emphasize that it's important to ask victims what they need, but reflecting on what Julie said earlier, sometimes they don't know, and that's what a good victim services professional is able to do, to help them understand the wide range of services available to them. I'm going to talk quickly about victims' rights, and I don't expect hospital administrators and staff to be legal gurus, but just a general awareness of the 32,000 rights that victims have across all states, D.C., and the territories. And 35 states, we're proud to say, actually have victims' rights embedded within their state constitutions, which gives them a little bit more juice. I'd love to tell you that the rights are standardized, but they are not. They differ state to state. But there are generally 10 core rights to information, notification, reasonable protection, and safety, restitution, and victim compensation, which we're going to talk a little bit more. And there is a handout on the AHA great website that specifically talks about the 10 core victims' rights. We've learned, unfortunately, from experience that MVI sometimes cross jurisdictions. They can be federal and tribal. They can be state and federal. There's a whole bunch of mixes in there. And so it's important to know that the Federal Crime Victims' Rights Act, or the CVRA, provides extensive victims' rights that often are a little bit different from states' rights. So again, the handout on 10 core victims' rights in CVRA can give you a little bit more information about that. We do want to talk a bit about victim compensation because it's super relevant and very, very important to hospitals and to healthcare professionals. Every single state has a crime victim compensation program. They differ just remarkably, but in general, there's a basic requirement for victims to cooperate with law enforcement and prosecution, which obviously that happens in MVI, and to submit a timely application to the state victim compensation program. We've learned, talk about lessons learned in MVI cases. You will now go to an initial response center, and they will literally have computers and cell phones set up where they can sit with victims, first responders, and others, help them process their cases, get law enforcement to sign off it at the response center, and send it directly into the state victim compensation program. And so what is often a delayed process is usually expedited in MVI cases, and that's something we're super proud of. For hospital administrators, it's important to know that comp can help cover costs, including but certainly not limited to medical expenses, which, listening to Julie's description of her physical impact can just be huge. Long-term mental and behavioral health counseling, really, really important. Funeral and burial costs. Lost wages or support if you're out of work or if you've lost the breadwinner because that person was murdered in MVI, they can help out with that. And very important to provide time off from work and funding so that victims can attend justice proceedings that are related to their case, which again can sometimes be very time intensive. Federal and state support for victim compensation. Just a quick overview. All states get federal funding from the Department of Justice, from the Victims of Crime Act. It's a pool of money that comes not from taxpayers' dollars, but from fines and fees assessed against convicted federal offenders. And in the aftermath of mass violence or terrorism, all victims are eligible for comp benefits. They're generally governed by applicable state statutes, and eligibility does vary significantly state to state. So depending on where your hospital is located, I just highly recommend that you contact the compensation program. They are your best friends, not just for MVI, but for other victims that hospitals see, and get more information about eligibility in the application process. Keeping with our theme of training and cross-training, it's super important that you bring comp people in to train your staff and that you also, as hospitals, be willing to train victim comp staff and other service providers about the services that you provide. And again, if you go to the fabulous AHA website, there's a map of state programs. You can click on your state and find specific contact information for the comp program that oversees your state activities. So we want to talk briefly about three different processes that have been established in the aftermath of mass violence incidents, again, from over 30 years of experiences. We're pretty good at that. The first is that literally as MVIs are occurring, and when you get the call or when I get the call, the response center is being established with plans in advance to do that. We used to call them reunification centers, realize that unfortunately some folks will never be reunified with their loved ones. So we now call them response centers, and they're usually set up just for the immediate aftermath up to about 48 hours after the MVI. The communities that have plans, and hospitals need to be part of these plans, they often have a centralized location that's designated in advance so that you have the setup that you need, so that people know that that is where we can make sure that victims and their loved ones who are looking for their victims can go to a place that is safe and secure, away from the prying eyes of the media, and that have direct linkages through the Joint Information Centers and the Joint Operations Centers to hospitals and to healthcare professionals. What follows, usually 24 to 48 hours after the initial response center, are programs called Family Assistance Center. OVC describes the purpose simply to facilitate the exchange of information and to address survivors and families' needs, which is, as we discussed, can be very, very extensive. They are there to address basic physical needs and emergency needs, and that's where our partnerships with hospitals become really, really important. They are there to link survivors and families and first responders to important short and moving into more long-term services, because as Julie described, I mean, the ripple effect and the long-term impact of MVIs on survivors, it lasts very often a lifetime. And very often there's online linkages to healthcare services and hospitals that can facilitate family notification and communications. As I noted earlier, and this is my personal experience, I don't have evidence base, but I do have lots of experience. We need to do a better job here with the online linkages so that we can track where victims are, and we can make sure that their families and victim service providers are able to immediately reach them to be able to provide the support and services that's super important to them. And Aurelia mentioned a newer phenomenon that we're super proud of at our center, and that is what we call resiliency centers, often established with funding from the U.S. Department of Justice that has a program called AEAP that provides coordinated services crossing what Aurelia earlier described, system and community-based services, again, local, state, tribal, federal, Department of Defense, and national jurisdictions. And the purpose is to provide ongoing support to survivors, families, first responders, and I would also add to communities that are often traumatized by mass violence incidents. One of the super cool things that resiliency centers offer are navigators. These are actually people, their job description is to know what's out there, including healthcare, to help victims identify and be able to access on an ongoing basis the wide range of not just victim services, but other government services and health services that are available to help them in their recovery process. These often involve direct health and wellness services, both traditional and non-traditional, and ongoing support in those areas. And anytime you see an annual observance of a mass violence incident, anytime you see a community memorial built to honor the survivors and those who were killed, that's usually organized and leadership is provided by the longer-term resiliency centers. At our center, we're super proud of the fact that we have created a Resiliency Center Directors Forum to share information, ideas, and resources. We currently have 14 members. That means 14 communities that have been impacted by MVIs as part of the forum, and the group grows on a monthly basis. Anytime there's a mass violence incident, we are there to provide them with support and invite them to join this really important group so that we can help them forecast and predict and prepare for the long-term recovery for survivors, for responders, and also for communities that are affected by mass violence incidents. I'm going to turn it over to Anna to talk about one of the most important things for hospitals, for survivors to be aware of, and that's vicarious trauma and burnout.
Thank you, Anne. One of the things that we've noticed that we've talked about a little bit today is that these mass casualty incidents seem to be happening more and more often as a part of the, I guess, almost normal job for providers. But it's really important to remember that while these events may be happening more often and they may seem to be just a part of the job for the providers, they are still very abnormal events, and our bodies and our hearts and our minds are really not naturally equipped to adjust easily to these events. And so these care providers, while themselves not injured in the incident, they're often overexposed to these abnormal events, and their normal reaction to this will look something like post-traumatic stress reactions, possibly difficulty sleeping or seeing the victims or the scene that they just worked in their minds over and over, or remembering conversations that they've had with those who are suffering or dying as they're providing their life-saving care. So we know through research that the impact of these events have a great effect on these health care providers. But the research on the impact of MVI on healthcare providers is a lot more limited, and we can hypothesize that the response would be pretty similar to those from other mass casualty events, but we just don't really have a lot of research in that. And what we can do as hospital systems is, I think most importantly, is recognize the fact that this is going to have an impact on our most important resource, which is our staff. And while we can't see their injuries, some percentage of our staff members will become less capable in their jobs if we don't have some way of addressing that. This is going to show up as staff turnover, very expensive, poor staff relations, maybe poor performance, and poor coping strategies that may look like self-harm. Partnering with VSPs and with the unique expertise in helping survivors cope and developing programs that validate this vicarious trauma is an important part of getting prepared. And Anne and Aurelia, you both were talking a little bit about this before we even started the webinar. I'm wondering if you wanted to kind of add a little something about this?
Well, thank you, Anna, and thank you for just validating how important this is to recognize vicarious trauma as something that is to be expected. I think I can speak for Aurelia and I both. We are experts in vicarious trauma, having gone through it ourselves, but also victim service providers. We do a lot of training on this because it's something that has a devastating impact on the professionals in our field. And so when we talk about cross-training, this is one of the areas, Anna, where I think hospitals and victim service providers can really join together, a great opportunity to share what we know about vicarious trauma, recognize that it is going to happen, and use our collective knowledge to be able to help. And thank you for saying our greatest resource, which is our respective staff. I appreciate that. And we are going to move on to a quick summary from Aurelia on how you all can partner with victim service programs and how you can link with victim service programs.
Thank you, Anne. That's so important that we begin to have community conversations about planning for mass violence incidents. And it's important that you partner with victim service programs. I will tell you that these programs will be so happy to hear from you. And if you just begin to establish relationships and begin to have that kind of connection, it makes a difference for the people that you serve. Having a warm handoff is essential. We all know in our real life how good it is to say, if you go down there to that particular store and tell them that Ann sent you, you'll get the best service. Or that restaurant, tell them, my friend said to come here. It makes a difference. And so it makes a difference when we provide the services by providing a handoff. Really means a lot to that victim. You're not sending them out there to the world just on a whim. Finding ways to collaborate and to establish partnerships really, as I said, isn't that difficult because advocates really want to do that. So if you reach into your community, many of you already have rape crisis centers or domestic violence centers or Mothers Against Drunk Driving or whatever those particular victim services might be. Having, sit down, have them to come out and start to have that conversation. Provide training about what services are available in your community. They may not know what's available in some of the great work that you guys are doing. And then let them, participate in their cross-training. I mean, we did it. I worked with Duke University Hospital for a long time. And it was nothing for us to have services with, cross-training with their staff, their medical teams. And we went out and talked to all of them about the services that we provided. We even held our trainings for our volunteers within the hospital setting, which was wonderful. They had great training facilities, and they made that available to us. And so with that, we started to have relationships with many of the hospital team, and it just worked out very well. So figuring out not only how you can work together, how you can participate in cross-training, but also looking at what are the gaps, what are the needs in our community, and how can we meet those needs, and never let a survivor leave your hospital without a solid referral for how they can get help and ongoing support. And lastly, I want to talk about linking victim service programs, linking with them. You have great resources online that are available to you no matter where you live to let you know what victim agencies are in your community. So you can search that online directory by where the services are, so where your community is, the type of services or victimization that they work with, the type of services they provide, and, of course, the name of that organization. There are 23 national toll-free numbers that are available. They're, again, a part of the handouts and part of your the AAH website that are available. And these resources can help you find local victim service programs. But if you're stuck and need help, please contact us at the National Crime Victim the National Mass Violence Victimization Resource Center, and we can help you to reach out to the victim service community in your area. And I'm going
Thank
to
you, Aurelia. And I'm going to second what you said. Victim service providers would love to hear from hospital professionals. That is just a partnership that if they don't already have, they would be eager to form one. So we're going to just do some hopefully inspirational closing thoughts about saving lives, improving care, empowering survivors, and developing solutions. And we're going to start with Dr. Anna, saving lives.
So, I know in the last webinar, we learned a little bit about community members being trained to save lives through Stop the Bleed programs. But when I think about saving lives in the context of this conversation, I think about those lives and the families that have been forever altered by this event and who have survived it, but are psychologically, emotionally, and socially changed forever. And so when I think of saving lives, I think about those lives we need to support to rebuild themselves through these resources and connections that you all have talked about today.
Thanks so much, Anna, and recognizing also that we're sometimes talking about a lifetime of recovery. This is something that is not a quick process for survivors and their families. Improving care, Aurelia, thoughts?
Well, I just keep thinking about how we have to continue to push for coordination and collaboration. We have to stop thinking, I think, sometimes in our traditional way, but be more inclusive and more willing to bring people into our circles. And we want to make certain that we provide, whatever we do, provide services to victims in a trauma-informed, evidence-based way. We want to help That's our goal. We want to improve their care, whether it's physical care, whether it's emotional care, psychological care, spiritual care, whatever that might be. Those are the ways that we want to work together to ensure that people are made whole.
Great. Thank you, Aurelia. And I can say there's nobody better than Julie to give us advice on how to empower survivors.
Thank you, Anne. My first thought is that a survivor needs to protect themselves, but also to take advantage of all services offered to them, even if they don't think they're needed, to reach out and make contact with those service providers, because you may not need it in the immediate weeks or months, but you may need it later. And if you've already made contact, then it makes it easier to outreach. I know immediately after an incident, there is help, but it's sometimes 6 months, a year, 2 years later, you feel like there's nothing there anymore. So if those connections have already been made, it's easier to reestablish them. Keep in contact with friends. And for me, it was finding something to do for other people. I made Stars of Hope to send to other mass violence incidents, and would send basically messages of hope. And lastly, I think reconnecting with the first responders and the medical, the doctors and nurses and the people who took care of me, who helped save my life, was super empowering, and it helped. It just closed up some loops that were still open, and it just helped a lot in my recovery.
Thank you so much, Julie, and you're my star of hope. I'm so glad you're part of this conversation. And in terms of how to develop solutions, I just want to say that partnership between the AHA and our center is the foundation. It's the very foundation for this. Hospital professionals and victim service providers, I'm going to go out and just say we're all dedicated people. We're all pretty smart people. We're all servant leaders. I mean, we share so much in terms of our philosophy in life and our commitment to serving others. And there is nowhere where that level of service is more critical than in the aftermath of MVIs. And so I wanted to say we can't do it alone. We can't be in silos. We have to see this as a co-opportunity to move forward as important partners across our nation. And one solution that we are seriously working on at our center, they always say there's an app for that. There actually is. Transcend is a new mobile app that our center is developing for survivors, their families, first responders, and others who would benefit from walking through prevention-oriented resources with a lot of self-help strategies. Really, really important to strengthen victims' capacity to understand what they need and to be able to access services. We are beta testing this right now, which is September 2020, and we will make sure we're in touch with the AHA to be sure that they're aware of this important service that's going to be available soon from the National Mass Violence Victimization Resource Center. So I want to say thank you, and I want to say thank you to our wonderful panelists, Julie Paez, Dr. Anna Newcomb, and my colleague, Aurelia Sands-Bell. I really want to thank the American Hospital Association, Advancing Health in America, my personal new best friends. I'm so proud of the work that you all do and so pleased of your commitment to partner with our center. So thank you. Please visit the center's website and know that a recording of this webinar and all of the resources from this and other webinars that we've cited is at the AHA wonderful website. I'm going to turn it back to David.
Thank you. Ladies and gentlemen, that concludes today's presentation. You may log off your webinars, and thank you for joining us today.